and the audience for the sixth MCNS webinar on a very interesting topic, which is pituitary adenoma. Practically each of us must be doing pituitary adenoma time and again. So what are the problems we come through across the pituitary adenoma surgery? We'll come to know, and this webinar would probably help in solving most of these problems. I thank the whole MCNS group, the president, Dr. Rohidas, then secretary, Dr. Milind Dunake, and Dr. Rote, for arranging this seminar so beautifully here. I would like to thank the speakers who put up their presentations, Dr. Ashish Suri, Dr. Sabah Memon, and Dr. Kaustubh Dindorkar, who would highlight many of these pituitary adenoma related problems during surgery. And then we have a very international level of panelists, Dr. Chandrasekhar Dev Pujari. Everybody knows about him. He has been a head of department of neurosurgery at Bombay Hospital for several years. He has also been presidents of NSI and ISPN and many others. I think I don't have to tell everybody. Everybody knows about him. So he is one panelist. Then Dr. Alvaro Cordoba. He is a neurosurgeon from Uruguay. He's currently the president of IFNE, and for next 2 years he will remain the president of IFNE. So he will also contribute to his best in this webinar. Then Dr. Walid Ajab. Walid Ajab is a neurosurgeon from Kuwait. He's past member of WFNS endoscopy and the present member of IFNE EC this year. He will also contribute to this webinar. Then there are moderators, Dr. Datta Majumdar. Dr. Datta Majumdar is HOD, LTMC and Sion Hospital presently, and he is very much interested in this kind of surgery, and that's why we put him on the moderators list, and he will give a pretty bit of pituitary adenoma surgery. And then myself. Besides that, I would like to thank the audience and start working on this webinar. I will invite Dr. Dattatreya Majumdar to introduce the rest and start the proceedings. Dr. Majumdar, please.
Thank you, Dr. Sankla. And I think we are all set to start the webinar after your excellent introduction. May I invite Dr. Kaustubh Dindorkar, who is the consultant neurosurgeon at the Dinanath Mangeshkar Hospital in Pune, which is a very frontline hospital in Pune and doing as an academic it's an academic institution with a DNB program. So, and Kaustubh has almost an experience for the past 20 years and is an accomplished surgeon with a very interest in skull-base cerebrovascular surgery and endoscopy. So, may I invite Kaustubh to start his talk on surgical management of pituitary tumors?
Thank you, Datta. I'll share my screen now. Thank you for those kind words of introduction.
Before Dr. Kaustubh starts, I would like to thank Dr. Abhay Kumar also.
So I thank MCNS and I thank Dr. Abhay Kumar for giving me this opportunity to present this talk. This talk is mostly aimed at neurosurgeons from Maharashtra who have just started their practice. The faculty which is present here is quite esteemed faculty, quite experienced one, but this talk is mostly for the young colleagues of mine who have started practice. So I begin with the history and evolution of pituitary surgery. And as you can see from the timeline, it started in 1889 by Victor Horsley, 1906 by Schaeffler. Halsted described the sublabial gingival incision for the initial exposure. And then the legendary Harvey Cushing has this peerless work of transpenoidal approach where he brought down his mortality to 4.5%. And there were then the further scope of pituitary surgery expanded with the use of endoscopy by Gerard Guillot, and Karl Storz revolutionized the endoscopy by introducing an external source of cold light, and Jules Hardy introduced the operating microscope for further refining the procedure. But the best informative account of the history and evolution was I found in this paper by Dr. Pujari, who's our esteemed panelist. This was in the Neurology India, May-June 2020. And it beautifully highlights the pituitary and all the landmarks in the pituitary surgery. So before going in for the pituitary surgery for pituitary adenomas, I want to share some facts and figures about the incidence, which is the commonest. It is 10 to 15% of intracranial tumors, 6% in autopsies, and the epidemiologic incidence has been increasing now because of either radiology or regular hormonal checkups. Now, to approach the pituitary tumors, I think it is very essential to understand the different classifications and gradings of that. The Hardy's, the Knopf's, and the Goel's classification is known, and further, the physiological classification for functioning and non-functioning adenomas, the histological types, which are categorized according to the staining type, cell origin, immunophenotype, and recently the transcription factors. And this is what has changed a little bit of management, where we always thought that pituitary adenomas were essentially very benign tumors, but we are seeing a lot of aggressive tumors. And so now the International Pituitary Pathology Club has labeled them as PITNETs and neuroendocrine tumors, due to which can encompass the unpredictable malignant behavior seen in some set of aggressive pituitary tumors. Though it is being said that endocrinologists may oppose this terminology, as it gives a misleading connotation to the pituitary adenomas, which are always thought to be very benign and manageable tumors. But with the advent of MRI and noting the invasion and aggressiveness, we are seeing a lot of these tumors now recurrent and following a very aggressive protocol. So the classification is basically based on these three types: the tumor type, whether it is micro, macro, or giant; the cell type, or the tumor grading criteria according to the invasion, proliferation, and the further grading, which is more. So this is the international, the European Pituitary Pathology Group. They have said that this is how the pituitary tumor should be reported, where a preoperative information, macroscopy, histology, immunohistochemistry, and the diagnosis should be maintained. And that will help us to form a good follow-up for pituitary tumors and grading, and for estimating whether the tumor is going to recur or follow a path. So there are some debates about this. Let's not go into it, as I am going to fall short of time. This is according to the cell lineage, how they are classified. And the grading of Hardy's and Knopf's is well known. The grade 0, 1, 2 are non-invasive, and the invasive ones are grade 3 and 4, which may be asymmetrical. Knopf's classification, as we know, is based on the tangential lines drawn from the supraclinoid ICA and the cavernous ICA, the medial, the intermediate, and the lateral lines. And this video shows grade 1, 2, the 3 going into the cavernous sinus superiorly, 3B inferiorly, and 4 encircling the entire carotid. So, but while reading these tumors on MRI scans, one must always see whether these kind of pictures, whether they are just an invasion or extension of the tumors. And it is very important to understand this concept, whether the tumor has just invaded through a natural defect in the medial wall of the cavernous sinus, or it has gone along with the coverings of the dura into the cavernous sinus, just extended into the cavernous sinus, or is it really invasive? This is what we have to have an idea before going in for the approach or the surgery. So this is again about the invasion and approach, where any invasion into the cellular erosion, bilaterally or retrocellular area or clivus, is considered as an aggressive nature of the tumor. So this is Goel's grading of pituitary tumors, where he graded them on the basis of the intact diaphragm ocelli. Grade 2 was where bilateral cavernous sinuses were involved, and the grade 3 where the lateral wall was, or the superior wall was breached and the tumor extended beyond the carotid, and grade 4 where there was significant extension into the circle of Willis, and also clival erosions and things like that, sphenoid erosion into the paranasal sinuses. So this is how we have to approach these tumors and decide and give an estimate of the recovery to the patient when we approach these tumors. So presenting factors, we know most of the times they are due to hypersecretion in functional tumors, in insufficiency because of mass effect. Then mass effect is mostly because of the chiasmal factors, visual loss, the most common ones, Cavernous sinus presentations are pretty rare, but headaches, giddiness, hypothalamic changes are pretty common in presentations. And patients can really present with vague signs and symptoms, just weak muscle and bones, to right to loss of body hair, drowsiness, seizures, and lot of variety of symptoms can be seen in this. So I'm going to go to the management. So when we think of a pituitary tumor, whether we want to first decide whether it's going to be a surgical treatment or a medical treatment, whether it's a microadenoma or macroadenoma. If it's a microadenoma and there is a hormonal abnormality, you have to find out whether there is excess or deficiency. Whenever there is an excess, it's a functional microadenoma and surgery is the choice. If it's a deficiency, we usually observe these tumors. Macroadenomas who present with visual compromise or hormonal deficiency are operated, and with no visual compromise, they are usually observed with serial MRIs and hormonal checkups. So this is a small sort of algorithm to see how they are managed. As I just mentioned, it's the same thing in an algorithm-based thing, where a macroincidentaloma, we will undergo a visual testing and a hormonal checkup, and if it is abnormal, surgery. So what are the differentials of pituitary adenomas? So they are quite typical by appearance, but when the lesion is cystic, then there can be a confusion. And that is where you have to see what is the epicenter of the lesion, whether it is above the diaphragm or below the diaphragm, or what is the relationship to the stalk and all these things. So the most common cystic lesions which are seen are the apoplexy, the pituitary cyst, hypophysitis, where the stalk is most of the times involved. Abscesses are seen, and then Rathke cleft cyst, craniopharyngiomas, arachnoid cyst, and so on. So treatment by first intention is for most of the macroadenomas. Immediate surgery is for when there is an impending loss. Emergency surgery in case of pituitary apoplexy or infarct. Delayed surgery after hormonal correction if patient is deficient in thyroid, and so on. I will not dwell on the radiotherapy and pharmacotherapy aspects. Goals of treatment are to relieve pressure and restore vision, preserve the pituitary function. Morphological and functional preservation is must. Inhibit the hormone secretion in microadenomas and avoid injury to neural and vascular structures. These are the four main goals. Preoperative evaluation is by endocrinologist who has an estimate of what the patient is going to behave like. Ophthalmological workup is fundus and perimetry. A contrast MRI, sometimes delayed contrast films for microadenomas are must. And CT scan with thin bone cuts if it's a redo pituitary tumor, or to look for previous removal of extent or new bone formation in redo cases. So CT scan is done in these few cases. So radiology comes nowadays, sometimes we can do these Fiesta sequences or contrast enhanced Fiesta to gauge the sort of firmness or the elasticity of the tumor. Even diffusion weighted MRI, there are papers where ADC maps can provide information about the consistency, and these are to be studied to estimate whether the tumor is soft, suckable, or hard. Most of the times you will get a good estimate on T2 images. So medical management, I think the next speaker is going to speak. So these are some of the prolactinomas. I just wanted to show the young colleagues of mine that these are very aggressive tumors, and they may just melt down with medical management after a couple of weeks or say a couple of months. So the only indication for prolactinoma surgery is when they have presented with CSF leak. And this is one of the patient of mine who presented only with the CSF leak. And I had to operate him despite knowing that it's an aggressive tumor. But after giving him medical management, the tumor has been pretty much under control for the past 3 years. There are no visual symptoms. So the only indications are hormone refractory when you want to do a decompression, or when there is a presentation with CSF leak. Surgery for microadenoma in acromegaly, the cure rates are pretty good, and you can almost see an instantaneous improvement in the patient's musculoskeletal features and his pains and aches. For Cushing's, the remission rates can be up to 80%, but over a period of years, they can drop down and recurrence rates are high. So the success of microadenoma surgery is based on good preoperative localization, and the approaches are pretty standard for them. But while probing the tumor, the protection of the normal gland is very important. And that's why I say that the preoperative localization is very, very important in microadenoma. Transsphenoid surgery. Now let's go to the technique of the transsphenoid surgery, where it is microscopic at many centers, where it can be done uninostril or binostril or sublabial. And there is significant injuries to the submucosal endoscopic technique, where the limitation, because you have to strip the mucosa of the septa. I just want to show a few figures so that people will understand it clearly. This is a microscopic technique where the nasal mucosa is lifted off the cartilaginous and the bony septum, and it is dissected right up to the sella. And on both the sides, where the hardy speculum is introduced to see the vomer, which is removed to enter the sphenoid cavity. So these are the standard steps in approaching the sphenoid cavity, where once you reach the sphenoid, the study of the sphenoid septae and the placement of the optic nerves and the carotid becomes of paramount importance when expanding the approach. So once adequate approach has been expanded, the sellar floor is cut off, chiseled off, or drilled, and then the dura is exposed with a cruciate incision and the tumor removed. Then the endoscopy and microscopy steps are most of the times same. While the transsphenoid endoscopic approach can be done with uni or binostril, the endoscope is introduced through the nostrils and main anatomical landmarks should be identified. The nostril forehand technique is highly recommended, and most of the people here are masters in this. Collaboration of two surgeons is necessary, a ENT surgeon and a neurosurgeon, but this needs proper tools and training. So this is just some of the prerequisites that I thought that the young neurosurgeon should know about attempting endoscopic pituitary tumor. Either they should have had training in their training period, they should have familiarity with the endoscopic anatomy of nose, sinuses, and the variations. They should team up with ENT surgeons who are quite helpful in holding the endoscope and also doing repairs. Equipment should be of good quality. Availability of endoscopic equipment like scissors, cautery, drills, probe, and navigation, which is optional, and adjuncts like fibrin glue with applicator should be there. So these are the steps of the pituitary, endoscopic pituitary, where you first identify the middle turbinate, and then the choana, go up and identify the sphenoid opening, widen up the sphenoid sinus, study the sellar floor, and then start the sellar floor drilling. So these are just few videos of a case which I did actually today, where the middle turbinate is cut. I'll just show them very briefly. The sphenoid ostium is identified, and sellar floor is, the sphenoid opening is widened, either with rongeurs or using drills. The attachments of the sphenoid septum studied properly. This is the final exposure of the sellar floor. And this is when you have got adequate exposure, you drill out the sella turcica. This is a patient of acromegaly, so the sella was quite thick. This is after the adequate sellar exposure, the dural exposure is there, the dura is cauterized. It is cut open, noting that the tip of the cutting edge is always placed inside. The tumor is biopsied first, and then if it is suckable, sucked on the inferior part.
Can you summarize in
first?
Also, time is
Yeah. I'll just go to some of the cases that I wanted to show, just 2-3 minutes. So these are the few cases. This is apoplexy and total removal with transsphenoid. This is another with a cavernous sinus, but with endoscopic guidance, a total removal has been done, only keeping a small, very small sinus residue. Another gingerbread man type of appearance, but if you see the sellar floor, it was very narrow. So we decided to go transcranial, and this is the total excision of the tumor. This is another patient with hemorrhage, and you can see that First of all, we thought that there was cavernous sinus involvement, but on doing a transsphenoid, total excision could be achieved. So another giant pituitary tumor, but with a very narrow dumbbell lower down. So operated by a combined approach. Patient had blindness, which improved significantly. You can see a total excision of the tumor. This is a recurrent tumor, and a small residue was seen at the end of a transsphenoid surgery, which is a stable residue and is under observation for the past 6 years or so. This is a giant tumor, but see the base of the tumor, which is quite favorable for endoscopic approach. And though there is quite a significant extension, the tumor could be totally removed just by transsphenoid endoscopic approach. Another patient where this is a giant tumor, there is a residue left at the end of the tumor. Actually, we thought that the invasion was more on the right side, but the residue is left on the left side with so I'll just rush through all these things. Another patient of acromegaly, actually. You can see a very fibrous tumor here. And this was tackled with combined transsphenoid and transcranial near total excision, except a cavernous sinus residue, which was later irradiated. This is an acromegaly patient with a significant extension. This is first approached by transsphenoid, and after transsphenoid surgery, because the tumor was fibrous, this was later operated by a transcranial route, and a near total excision was achieved. So these are few of the large tumors that we have used. So this another point where in acromegaly, you could find this picture of carotids coming very close and kissing carotids. One has to be very careful about this. This is a large giant tumor, which was just totally excised with transphenoid only. This is where I first learned the value of opening up the medial wall, where there was a medial wall of the cavernous sinus, because I operated this transsphenoid and this was the residue, and I could not find anything in the sella. After the second TSS, I could remove this tumor, and that was when I thought that this was the trick to removing the tumor in the medial wall along with the medial wall of the cavernous sinus, if it is soft. So for want of time, I will just rush through the videos and go to these are some of the very fibrous tumors, very invasive and very difficult to remove. So this was approached transcranially, but it was extremely difficult. All the perforators were there. I will not share the video. This is another recurrent tumor operated somewhere else, which was operated transcranially. And this is the final picture that I would like to show you, where all the structures were well delineated and the tumor was completely resected. I will not go into the CSF. So this is the protocol for follow-up and management of the residue, that we do a third-day assessment of hormones and imaging in transcranial approaches, ENT checkup at 2 weeks, MRI at 3 months. If there is no residue, then yearly follow-up MRI for 5 years. If there is a residue, then 6 monthly MRI. If it's a stable residue, 6 monthly MRI for 2 years. If there is growth, then the patient is either undergoes a resurgery or radiotherapy or hormonal treatment, depending on his functional status. So radiation only for aggressive tumors, which are sometimes very difficult to remove. Complications, as you all know, the most dreaded ones are the arterial ones, but even venous lake injuries or venous sinus injuries can be very dangerous, and you should have balloon occlusion or facility of a cath lab to do an angiography, or stent deployment should be at hand. Post-operative can be CSF leak, apoplexy due to partial excision, recurrence, endocrine abnormalities, seizures, and hypothalamic dysfunctions. Delayed complications are again hormonal mostly, and some nasal sinus related complications. So to conclude my talk, I think these are pituitary tumors are common treatable tumors with good outcomes, and everybody should focus their energy and time on learning the approaches. It's a team approach by neurosurgeon, ENT, and an endocrinologist. You have to train for endoscopic approaches, repair of the skull base, and salvage situations. Assessment is very important preoperatively about the hormones, radiology, and anatomical variations. Strict follow-up is very important, and long-term follow-up is necessary in all these cases. Thank you very much.
Thank you, Kaustubh. I think that was quite elaborate and exhaustive, covering the entire aspect of pituitary tumors, right from the incidence to the latest and your experience. That's quite commendable. I think we should go for the second talk, Dr. Sankla, or we have some discussion.
Alvera, do you have anything to say? Otherwise, we'll go for the second one.
I think this is very complete review. It's a very difficult review in 25 minutes, more than 120 years, a lot of approaches. It's very interesting. The only thing perhaps if you find perhaps a prolactinoma with a CSF leak, and you start with medical treatment.
Yes.
What shall we do, Dr. Dindokar, with the CSF leak? We must to wait, we must to correct, because they takes a long time perhaps to improve the size of the tumor and to repair spontaneously the CSF leak. So it's not so easy to, in this case, they are very difficult to decide.
Yes,
what do you think about
what
this?
do you think?
So this patient presented with a leak, and there was a large gap. So our intention was not to excise the tumor, but just the tumor which had invaded the sphenoid sinus, we excised and put in a graft and glue. I was worried about the patient came from a village, and I was worried about whether he would get meningitis and would be lost to follow-up. But after the CSF, the patient primarily came for a CSF leak. So I don't know whether and it was quite a copious leak.
So I think endocrinologists would also want the patient to undergo surgery to plug the CSF leak and remove the tumor to the best, whatever is possible.
Yeah, for sure.
Yes,
okay, this is the only.
Walid is there now.
Yeah, back to that point of the CSF leakage while it is under the medical treatment, I think that it is very wise to close the CSF leak, because you don't know when is the meningitis going to happen. And I have had maybe 2 or 3 cases of that similar scenario, which necessitated a closure, because one of them developed actually a severe meningitis and she had to be under treatment. So you just seal everything perfectly and you continue with the medical treatment so that the remainder of the tumor goes away.
Exactly.
Dr. Devpujari,
yeah.
You want to say something, Dr. Devpujari?
I think it has been covered quite well. I think 2 basic things I would like to say, which Kaustubh probably missed out. One is the importance of doing a preoperative CT scan.
Yes.
I think it is a very important, if you are going to operate by transsphenoidal approach or transcranial approach. One of the important things I find that I would definitely like to see a skull-based CT before I decide on the approach, and it also helps me as to how much I need to drill and which areas I can reach and which areas I cannot reach. So I would consider that as a part of preoperative workup. MRI, however good it is, may not be the only thing. I especially if I'm going to do an endoscopic surgery and if I'm thinking of extending anything, I would like to know that was one point. And second point is, I think one thing you have to probably consider in mind, are we doing a tumor? Sorry. Are we going to do a tumor excision? Our main aim is decompression or tumor excision. Complete tumor excision may not always be possible unless the tumor is restricted in its boundaries. So I think that is another thing which will determine if you anticipate CSF leak or not and take necessary steps accordingly. That's it really. Otherwise, it is well covered.
Just last comment, if I can make, that my understanding in prolactinomas was that if the tumor shrinks with hormonal treatment, then the leak would in fact worsen.
Yes. No, so that needs to be repaired. I think everybody is worried about the fact that the tumor may become more fibrous and how much do you actually remove. So I think that you have answered adequately.
Thank you.
one question is there, how useful do you say the use of navigation?
I mean, the cases he showed like kissing carotid, I think I would probably use navigation. If I feel that I want to enter cavernous sinus, I would use navigation. If there is a significant suprasellar component which might necessitate more bone removal, I would use, because one of the major reasons why we fail in doing a good excision is probably inadequate exposure, and that is helped by having navigation at hand.
Okay. Thank you, sir. I think we go for the second talk now. If there are no more questions, we go on to the medical management of pituitary tumors, and I would like to invite Dr. Saba Mehman, who is a well-accomplished endocrinologist. She is assistant professor of endocrinology at the KEM hospital, and she is a gold medalist and has several publications to her credit and awards. So I think we are very eager to listen to Saba, and welcome, Saba. I think yours is the most enlightening lecture will be, because we need to know when and how, when to intervene and how to follow up this patient. Thank you.
Sure. Thank you for the introduction. I'll just be sharing my slide in just 1 second. Yeah. Is my slide visible?
Yes, we are.
Yeah.
Please
Thank
go.
you so much for the introduction. So the topic which was assigned to me was medical treatment of pituitary tumors. And while endeavoring to do so, I would also want to touch upon a few aspects which an endocrinologist can help in the evaluation of pituitary tumors. So it would both be a pre and a post-operative cover in which what we can add on to you. So the first essential part when we look into a patient who has a pituitary tumor is to really confirm that what we are seeing is a pituitary tumor. I have put across 3 different cases, all of these patients having some or the other hormonal or clinical abnormality with an MRI finding. However, they are not pituitary adenoma. So the first patient, while she does have a history, clinically we can see that she has a squint in her hormonal profile, her cortisol is low. She's actually a case of lymphocytic hypophysitis, where after steroids, the mass actually disappears. The next patient, clinically, biochemically proven, confirmed acromegaly, is actually having a pituitary hyperplasia due to a GHRH producing carcinoid, while the third patient is actually pituitary hyperplasia due to uncontrolled severe hypothyroidism with the TSH, which is so high. So the first thing essentially is to be sure that what we are dealing with is not an inflammatory or a hyperplastic change, but a pituitary adenoma per se. The second most important aspect which we need to really understand is what pituitary axis do we need to evaluate and what are the differences which we observe in them. So if I have a patient with pituitary incidentaloma, these specifically would be my wish list for all of these patients as well. And as we understand, across different pituitary axes, there are different kinds of clinical presentation and different investigations which I would order specifically for each patient. So as discussed exhaustively and extensively, prolactinoma is the drug with the tumor which is actually medically managed through and through. And prolactinomas can come across different flavors, from being a microadenoma, a macroadenoma, or being a giant. And as we understand that across each and every one of them, the treatment involves use of cabergoline it only. And cabergoline is essentially the first line therapy, because we have seen even in our patients, starting even 2 doses of cabergoline can make a difference, even if this patient had at the onset changes, even involving optic nerves or field defects, which actually improve once you start treatment. The improvement can be dramatic. We have had giant prolactinomas which would resolve completely. If not complete, most of them would actually have a partial response. And the further management really depends upon if the residual tumor volume is still troubling us to cause a vision defect or not. Sometimes, unfortunately, we do have prolactinomas which do not respond. And in those patients, we do end up asking the surgeon for helping us out. Another one important aspect which we've noted in the resistant prolactinomas could be those who are cystic or those who have some amount of GH co-secretion where really drug therapy is not useful. Drug intolerance to cabergoline, we have noticed in few patients drug-related complications, namely CSF rhinorrhea and psychiatric issues. We have had patients who have had impulse control disorders because of cabergoline when we just went back and withdrawn the cabergoline, or apoplexy. However, in our series of patients, we do have patients with apoplexy, with giant prolactinomas who were also managed conservatively. And amongst these, as we understand in an apoplexy, clinically also those who really have more deteriorating consciousness or more severe involvement of visual acuity, those are the ones who have higher PAS scores, more than 4, invariably end up with surgery. But the lower ones, or even with at the cusp of past 4, these patients on cabergoline actually recovered with their neuro deficits as well. And as we understand that in prolactinoma, if surgery is taken as a first-line therapy, most of the times it is still not able to completely resolve the hormonal issues. And nearly almost all of them in this series of ours, which was collated on pediatric giant prolactinoma, nearly all of those patients who underwent first-line surgery did eventually require cabergoline for control. And what was observed that the hormonal response which was there in these patients who had first received surgery was actually poorer as compared to those in whom we had initially begun with cabergoline in the first instance. This case I actually just added as a last moment right now when this discussion of CSF rhinorrhea was ongoing, to understand that when we have tumors in which there is a breach at both the levels, at the nasal cavity level and at the meningeal level, we expect CSF rhinorrhea. And in these particular patients, we are really cautious. We admit them for the first week when we are starting cabergoline because we are worried about CSF rhinorrhea. And if it happens, we really go ahead and stop the therapy, get it repaired. And once the rhinorrhea really stops, that is the time when we restart. When we restart, we really start at the very small dose. We would not go on to give them a full dose because there we just want to ensure that the rhinorrhea is not acceptable at all. Moving on to other functioning endocrine tumors, the medical management preoperatively in acromegaly, as we understand the tests which we do are both GH and IGF-1. IGF-1 is the test which we rely upon for diagnosis. A random growth hormone really doesn't help. When it's really high in a patient with this clinical features, probably it's not a question, but when it's borderline, we even do a post-glucose growth hormone levels to ensure that we are really dealing with an acromegaly. And in an acromegaly, the most important pre-op concern actually is to normalize their blood glucose level. This patient had an HbA1c of 16. These patients require such huge doses of insulin that we really have to work hard in those patients. So there's a group of acromegalies which actually have poor metabolic control. Octreotide as a pre-op management we've used in very sparingly, especially those in whom the headache is so severe that or if the surgery is delayed or if the anesthetist thinks that the soft tissue overgrowth is so bad that the anesthesia is at a high risk, but that's very one-off situation. Cushing's syndrome, on the other instance, when we have a patient who has come with weight gain, plethora, striae, edema, diagnosis of Cushing's is not that difficult clinically when it's such marked and obvious. But the test for Cushing's would probably not just stop at a basal cortisol. Here, we actually have to do a dexamethasone suppressed cortisol to ensure that it's really not getting suppressed. We then go ahead and do an ACTH to find out that, yes, it's coming from a pituitary or an ectopic and not an adrenal cause. And the actual problems which we face through in a pre-op optimization of a Cushing syndrome, first and foremost, essentially is to localize and give us the confidence that this patient who clinically has Cushing's actually has Cushing's disease. That means has a pituitary adenoma, which is causing it. Because unlike acros, these tumors are most often so small, so difficult to find and localize that it becomes a very big thing. They even end up going through IPSS, that is the inferior petrosal sinus sampling, before we send them to a neurosurgeon. In a Cushing syndrome, the metabolic optimization becomes really, really difficult and important. They have wide amount of issues which need to be taken care of. The glucose levels, hypokalemia, which can be real severe, hypokalemia related poor muscle mass. We really put them on spirometer intensive exercises because we want them to come out of the anesthesia. Patients with real severe Cushing also eventually end up getting anticoagulation because we are worried about them having thrombotic events. infections are sometimes real serious concerns, and hypercortisolemia per se, treating the cortisol excess before surgery, we eventually end up doing so in a fraction of patients. This is the slide which I really wanted to highlight about why the localization is so very important, because we can see this is actually a case report wherein this is Cushing's. You can see a microadenoma operated, uncured, and turns out that there was an adrenocortical carcinoma sitting there, which was causing the Cushing's and which was missed, delayed, and eventually ended up with metastasis. So even if you can see an adenoma in an MRI in a patient of Cushing's, please send them off to us. Let us have the onus of telling you that, yes, this is a disease and please operate it. We have had a patient with pseudo-Cushing, patient who is just depressed, and that is the reason why they are having all of these abnormalities, where when we do an ODS cortisol, whether we do a urinary cortisol, salivary cortisol, everything comes haywire. But when we do a low-dose dexamethasone suppression, that is a prolonged dexamethasone suppression, they actually suppress, and they do not have a disease, they just have a depression which needs to be treated. Or an ectopic Cushing's, wherein you can see both an MRI incidentaloma and a PNET sitting in the pancreas, which is actually causing the Cushing's. So this is a real challenge for us. And across the medical management, as I said, most of the drugs which are used in medical management, only few of them are actually available to us. And in our practice, we end up using mostly ketoconazole, etomidate in some cases wherein they are admitted and they have an acute issue as well. To talk about stomas, these are basically tumors which are producing TSH, because of which the T3 and the T4 levels are really high in these patients. Despite such high levels of T3, T4, whenever TSH is high, we still need to confirm that we're looking at a tumor which is producing the TSH, or whether this patient is actually having a TSH resistance syndrome, which can have a mimicker of a profile. And here, just starting the patient on carbimazole is not enough. We actually have to go on to the extent of giving them octreotide to bring their T4 levels to a range which is acceptable enough that they do not end up with a crisis during their surgery. And rarely we even come across functioning gonadotropinomas, as was seen in this particular female who presented with irregular menses, pain in abdomen, cystic ovaries, large pituitary mass, and it was labeled as a prolactinoma because the prolactin was high. And actually, this patient's adenoma was secreting FSH, which was driving this prolactin and the cystic ovaries. And this patient, once you give cabergoline, yes, the prolactin will be 0, but the tumor will not shrink because the tumor is a gonadotropinoma. So now switching gears altogether to hormonal deficiencies, each of these parameters across a long time can cause deficiencies, and their evaluation actually goes on to stimulating those axes. But when I'm talking of a preoperative evaluation, essentially cortisol and thyroxine are the ones which I have to normalize before I subject my patient to surgery. Hypopituitarism in an acute setting is something which occurs in patients with pituitary apoplexy, wherein the cortisol goes really low. The free T4 can also go low. And in these patients, as I was talking about in my patients with prolactinoma as well, when the axis, when they have just isolated field defect or a sensorium which is not worsening, even conserving these patients can resolve their neurodeficits and their hormonal axes. So another additional aspect definitely is to rule out syndromic approach. Just giving a cabergoline to a prolactinoma is not enough if that patient is a case of Menvin syndrome, who years down the line ends up with a severe hypoglycemia and an insulinoma which was missed, who ends up with renal calculi and a bad creatinine because the hyperpara was missed. So in addition to the pre-op evaluation, post-operatively, these are the factors which we really look into. The steroid cover perioperatively is the most essential one. Even if preoperatively my steroid levels are absolutely normal, as a rule, on an average, we always ask the anesthetist to give a hydrocortisone cover before the surgery is happening and perioperatively, because identifying or evaluating for steroid axis perioperatively is not that easy. There are centers who actually serially monitor the cortisol axis. That is, they do cortisols 8 hourly for the next 3 to 4 days, and when it drops, they replace. Rather than that, we do a more conservative approach. We assume that all cortisols are going to be low. Over-treating for a few days is not going to kill my patient. But if I under-treat and I'll end up with an abnormality, that's probably not okay. So in our center, we prefer to routinely start steroid replacement for any patient who's undergone pituitary surgery. we actually discharge them on a very low dose of steroids, which would be just probably a 2.5 milligram prednisolone. Because believe me, we have seen patients who have gone home, ended up with seizures and hyponatremia 8 to 10 days later because they did not take their steroids. So if I'm putting them on a 2.5 milligram, at least mentally, I can sleep well at night that I have not missed out on anything. Follow-up evaluation. On follow-up, these are the 3 axes which we will look out for. We will look out for them at 3 months. We will probably evaluate them at least yearly. And believe me, even if initially, perioperatively, you do these axes, they may not be good enough to tell you. T4 has a half-life of 7 days. So even if today you knock off my pituitary, I will still have normal levels of T4 for the next 2 to 3 weeks. It may not become 0. And if you do it at 3 days and you forget it, this patient will actually be a patient who is hypothyroid, having fatigue, muscle cramps, hyponatremia, and troubled for life. So we do assess all of these axes at 3 months, because at that time, that would have been enough of time for the pituitary to have adjusted to whatever stress in those 3 months, 2.5 milligrams of prednisolone, so that at least I'm comfortable that I'm not missed out on anything greater. The immediate peri-op hormonal electrolyte abnormalities, which happens, as we understand, is when we transect the stock, we expect that there would be a deficiency of vasopressin, that the patient should have diabetes insipidus. But what happens is that there is actually, instead of no AVP being a simple thing, it is actually a little bit complex, that even initially when the stock is completely shut off, whatever stored amount of vasopressin is there, is the pituitary goes into shock and doesn't release that. So in the initial few phases, the patient can have a diabetes insipidus phase, which may or may not be there. For the next 4 to 10 days, they can have unregulated release of vasopressin, hyponatremia, and later on, once all of the stores are exhausted, the patient ends up with the total diabetes insipidus. And herein comes the importance of what we would insist, or which we follow in our center, is 12-hour sodium monitoring, strict intake output charting for all of the patients who undergo pituitary surgery. This is a patient who is actually a case of acromegaly. And as you can see in the initial second post-op day, the patient actually pours out 9.5 liters of fluids. And while doing so, the sodium remains normal. So because this pouring out of fluid is because of breaking down of glycosaminoglycans, which happens in a severe acromegaly, which is actually curing, and this patient does not actually have a DI or SIADH. In these initial 2 or 3 days, especially in those whom the transaction has been severe, they can actually have DI from a few hours after the surgery. Here it is very important that even if I'm replacing vasopressin, I do it very, very cautiously, because I'm worried that after 4th day, this patient is going to become hyponatremic. I'm worried that when I'm replacing it, I would probably give it just as a bolus dose, SOS 4 units, or probably as an infusion, which would be just 0.5 units per hour, and titrate it to output. The output goes better. Output peaks up again, I repeat a bolus dose. If it's fine, I don't do it. Giving a spray at this time is really worrisome, because a spray has a half-life of almost 24 hours. Giving a spray 3 times a day and ending up the patient in a severe hyponatremia is absolutely no. So when we're replacing it, either it is an SOS bolus dose or an infusion or a tablet, if at all you're thinking of giving a spray, it would be just once a day, just for the initial days. And you would probably think of reassessing once the output goes low. And this is what happens after the 4th day. The sodium start to drop. And output, which is in 4 liters, becomes 800. And here, just even restricting the intake does my trick for me. In some patients in whom it becomes real severe, I may even resort to giving them a transient 3% NS, and later on the patient may or may not develop a permanent diabetes insipidus. And as I said, the monitoring for a functional tumors is again something which I would like to put on board. If I have a patient with acromegaly on day 5, I'm only interested in GH, because the IGF-1 has a long half-life. It is going to remain elevated no matter whether the tumor is cured or not. The IGF-1 comes down 3 months down the line. For a Cushing's, it is both the cortisol and the ACTH at 8 a.m. on the 5th day, to ensure that I'm really resolved or not. Again, to ensure that the peri-op steroid cover before I'm doing the cortisol would be a dexamethasone and not prednisolone or hydrocortisone, to ensure that I'm not overestimating my cortisol levels. The follow-up evaluation for the other tumors is essentially straightforward. And this is another thing which I would want to highlight. Once a pituitary tumor patient is a functional tumor, specifically look at this patient of Cushing's, she's having a tumor, she's undergone surgery, she's cured, she's really cured, her ODS cortisols are undetectable. and she recurs. And she recurs 3 years down the line. Cushing's can recur 10 years down the line. So if we have patients of ours who have functional tumors, we keep them on lifelong follow-up. If they are functional, they can come back. They can come back at any time. If we can pick them up early, if we can pick them up when their ODS is so small, when the tumor is practically not visualized, we can give a radiotherapy and get away with it. If I don't, and I end up with a second surgery, and it becomes a little difficult. So I hope I was able to cover the different aspects of endocrine management of a pituitary tumor, and I would be glad to take any questions. And I would acknowledge my department for the slides and the patients which were offered.
Thank you, Sabha. I think this was a game changer, and you are come from one of the foremost endocrine departments in the country. For our panelists, the KM endocrinology department is one of the first endocrine departments in the country with a robust experience, and that reflects from Sabha's talk, that how elaborate it is for the surgeons to know the course of what the endocrinologist is thinking. So thank you, Sabha, and it has been a great day. Any questions from the audience, from the panel?
I have one question.
Yes, sir.
So this was about follow-up hormonal profile for the acromegaly patients, and you rightly said that IGF should not be done the next day, and only GH should be tested. I think you are on mute.
Sabha, you are on mute.
No, I'm not on mute. Yes, at day 5, we only do GH. We do not do IGF-1. IGF-1 has a long half-life.
So long is how much? Two
long
weeks?
is actually 3 weeks.
3 weeks. So what do we monitor in the late course? What do we monitor, the IGF or the GH?
So on day 5, it is always GH to tell me how much is remaining. In the long term, after 3 months, it's always IGF-1.
IGF.
Because it's then the dose for medical therapy depends on how many times IGF-1 is on the upper limit of normal. GH on a long-term follow-up doesn't really add on a lot.
Dr. Devpujari.
Can I ask Dr. Sabha? I think the current practice with most surgeons for GH secreting tumors is like they are doing GH levels at the end of surgery, or certainly in the first 24 hours. And that has been the practice which we are following, and seems to give us a reasonable idea about the future of the patient, depending on how low. So what is the cutoff value currently which you would follow? Say that you have had a satisfactory hormonal, if not cure, at least a good remission.
So if the GH is less than 1, we are really very happy. At less than 5 also, we are practically okay. But anything above that, we are worried. But as I said,
most of the time,
whatever access we do at 5 months, we always reassess at 3 months, because there is always a concept of a delayed remission which can happen, that whatever neurovascular structures were changed during the surgery, the remaining tumor can die by itself and we may get a good response.
I have one question myself. You talked about, continuing a small dose of dexamethasone to prevent the 7-day hyponatremia, or whatever you call it, delayed hyponatremia in these patients. Does it really prevent, number one? And when do you actually stop it? Because what we have started doing is we stop unless the patient is deficient, we would stop the steroids on after 48 hours. And we always reassess, wherever the patient goes, because patient doesn't usually stay for a week, that they must do their serum sodium or electrolytes at the end of a week, and they should send it, and they should do it after another week and send it, and we continue it for 3 weeks. Is that a reasonable policy, or?
That is definitely reasonable for monitoring for hyponatremia, but for cortisol, believe me, I have seen patients with empty sella who have had hyponatremia becoming so severe intermittently that they've ended up with emergency. They've actually been overcorrected. So no, cortisol, we actually feel that putting a small 2.5 milligram dose is practically a very small replacement dose, and reassessing at 3 months. 3 months is the time when I redo a cortisol. If it's normal, I stop it altogether. And if I'm only covering,
is it true that if you use, is it true that if you use hydrocortisone rather than prednisolone, you can stop it in say 48 hours, and you can reassess the cortisol levels in another 24 hours? Or will that be fallacious?
So for assessing, if you're giving hydrocortisone, it is always going to be detected in the cortisol assay. So you will definitely stop the hydrocortisone 24 hours before you measure a serum cortisol.
Correct.
But when
Yeah.
we're talking in principle about how long should I continue a replacement, ideally it should be as long till I'm sure that the patient doesn't require it. And for that, as I said, I could have a delayed tumor remission and a delayed thing. So 3 months is my reasonable comfort zone where I know that patient is going to come back for follow-up. And if this time the cortisol is even more than 5, I'm comfortable to just stop it altogether and say that, you are probably okay. You may just ensure that you could require a stress cover. Maybe at your next 3 monthly follow-up, redo, and probably it crosses 10 and we are in a good zone. So for hyponatremia, not so much. So it may not just be hyponatremia. Hypocortisolism can have even subtle manifestations like just fatigue. I mean, it's like a hormone which you require for recovery. It's a stress hormone. Even if I'm normally producing enough cortisol, I have to recover from a stress of a pituitary surgery. Probably putting a smallish dose is not that big, but it has to be a very, very small dose. The small dose is literally just 2.5 milligram prednisolone, nothing more than that. Even 5 or 7.5 will make my patient Cushingoid. I don't want to go there.
About 2 questions. How long will you give cabergoline for prolactinoma? And how do you manage permanent diabetes insipidus?
Cabergoline for prolactinoma is effectively lifelong. Unless you are looking at a microprolactinoma where a patient on replacement 2 years down the line is having a prolactin less than the normal range. Okay, so if it's less than 5, then I start bringing it down from even weekly, once in 10 days, once in 15 days, and then I stop. But if I'm having a macro or a giant, it's essentially lifelong. Permanent diabetes insipidus, these patients have to be on replacement with vasopressin. Essentially, what we have available is desmopressin. It is available either as a spray or a tablet. Usually just giving spray 1 puff at night works. Some patients have breakthrough. They may require additional half a tablet somewhere in the daytime if their output is too high, but it is always titrated according to how the urine output is. So if I'm giving a spray at night, the patient should have a breakthrough urine for at least 2 or 3 hours before the next spray is required the next night. If there is no breakthrough altogether, then I will ask the patient not to take the spray on Saturday nights. Let him pour out on Sunday, because over-treating with vasopressin and ending up with hyponatremia is even worse. Or alternatively, switch to tablets. Tablets have a shorter duration of action, and then you can titrate them BD depending on the sodium and the urine out. It's a game. It's not easy.
Thank you, Zaba.
Yes,
Any comment from our panelists, our esteemed panelists? Yes, Walid.
And CSF rhinorrhea probably is the condition where we'll stop it cabergoline for a while.
We stop cabergoline. We are worried that we will end up with CSF rhinorrhea. Let the tumor be a little more, let it plug the places till my surgeon is able to give me a green signal. And even if I start on a very, very small dose under very strict observation. There, the point is that I cannot do a harm. CSF rhinorrhea is scary. We just probably think that the prolactinoma, the worst what it can do is cause hypogonadism. I can replace testosterone and OC pills, but I'm not comfortable if I'm ending up with a meningitis.
Walid, Dr. Walid.
Just a few comment on the issue of the Dostinex, the cabergoline for the prolactinomas in those who have visual impairment. I, of course, do agree with you that Dostinex takes the visual problem back and it is very effective, except in some very exceptional cases when the visual impairment is severe and acute. Because in those, you cannot afford to leave the probability of losing the vision or having a permanent visual issue on the medication. So if it is acute, I mean happening within a very short time, and it is very significant, I think surgery would be a better option in that scenario, in my opinion.
Yeah.
And another point that there is some, although they are, and of course you know about that, that some of the, especially in very large tumors, prolactin secreting adenomas, in some cases the Dostinex leads to an apoplexy itself. The association between the medicine and the apoplexy is also something that should be taken in consideration. I mean, we should have a good access to the patient, like follow up, and he has a good access to us whenever something like that happens, because urgent surgery by that time would be needed. What do you think?
What do you think, Saba?
When we have a giant prolactinoma, which is so huge, we would really admit them for 1 week under us. We'll give them 2 doses of cabergoline, 0.5 milligram today. 3 days later. And in our experience, most of the patients, no matter what the visual axis is, if you've given one dose today, by tomorrow, they're going to be better. By 3 days, by the next dose, and by the end of 1 week, when we're actually planning for discharge, the visual acuity would have improved a lot. So clinically, in our setting, we actually believe that cabergoline really makes the difference. What we actually have with us is a very good neurosurgery collaboration. And if at the end of 1 week, if I'm worried nothing is happening, my surgeon is always there to help me out. That's one aspect.
Yeah.
The second aspect is, as I said, if it's really large, if it's the first 1 week, they're under my observation. So if they're really developing any symptoms of apoplexy, which is a severe headache or something, we really can look into them as what's going wrong. So when we have a giant, large tumors, I'm really, really worried that I'm going to end up with a CSF rhinorrhea, or how my response is going to be the first week they are under my observation. I cannot afford to not see what I'm doing.
Great.
Thank you, Sabha. Ashish, yes.
Ashish, yes, the last question.
Yeah,
Yeah,
Ashish,
can I-
last
can
question.
very, very interesting talk, Sabha. It's remarkable. Really enjoyed. What is your opinion on cabergoline-resistant prolactinomas, and how high of dose? Because I see some patients, even before they start temozolomide or elsewhere, they go up to 6 to 8 tablets in a week or so. So what is the highest dose that you recommend, and how do you titrate that?
So we have given up till 7 milligram per week also, but probably we've, and as of now, come down to only 3.5 milligram per week. If they're taking one tablet daily for 7 days consecutively, and I'm seeing that the response is not good enough, that is the time when I need to understand what is my treatment goal. As I said, from functional aspect, I really don't care. My prolactinoma is at best going to cause me a hypogonadism, which I can replace either ways. My functional goal, my goal in that patient is saving the visual axis and the mass effects. So if even in resistant prolactinomas, as I said, most of them will have partial response. And if in terms of a partial response, I'm able to get a tumor contained enough so much so that the visual axis are doing good, I'm probably okay keeping this patient at 3.5 milligram, or even bringing down to 2 milligram per week, so much so just my target being the tumor doesn't grow. But in case it does, then we probably step back everything, hand over the patient to a surgeon. Then we're going to treat it like a non-functioning pituitary adenoma. Please debulk as much as you can. Please go ahead, do temozolomide, do radiotherapy, do what we can. Because then if my vision axis is not improved with cabergoline, that is the time I step back and I involve my neurosurgeons on.
Thank you. Thank you, Sabha.
Thank
I
you.
think that has been a great talk. So I think we sure because of the lack of time, we go to the next topic. I have, with great pleasure, I have to introduce my great good friend, Dr. Ashish Suri, who's professor, esteemed professor of neurosurgery at the famed All India Institute of Neurosciences, New Delhi. And his basic interests are neuroendoscopy, skull base, and cerebrovascular. Ashish is going to talk on surgical management of pituitary tumors. We are eager to learn from you, Ashish. Please go ahead.
Yeah, can I share my screen? Thank you for the kind invitation. And how do I share?
You have a share screen at the bottom.
Let's see.
The green one.
It is open system settings.
No, on the screen you have a share screen option, right?
Yeah, but the moment I click that, it says open system settings.
Open. Can anybody from the technical team help him?
Yeah.
Please?
Can we help him from this side?
So you open system settings.
Yeah.
In system settings, you will see Zoom, enable Zoom. And then it will say restart Zoom. So you say later.
Yeah, unless they start making Apple computers in India, I think it is going to be.
Quit and reopen, it says later.
Don't quit and reopen.
And now I can share again.
Yeah. Now you can share.
Oh, but I was Zoom friendly. I suddenly become.
You can see your slides, Ashish. Please go ahead.
It says.
Yeah. You have to give access. Open system settings. Okay.
Yeah, thank you. I think, am I visible? Yeah.
Yes.
I think the Delhi is tasting. New Delhi is tasting Mumbai's monsoons. The monsoons are not finishing. And it took me from my hospital 7 kilometers, quarter 2 hours to reach. I'm sorry for the upset.
No problem. We are eager to listen to you.
Yeah, so I've been asked to talk about surgical treatment of pituitary adenomas. Very good lectures, So this is one tumor. There are two tumors which actually completely humble me and ground, and then I in the end, after I blame it on my better half is a neuropathologist, and I said it's not my fault. It's ultimately the molecular pathology that happens. So pituitary adenomas is one. Petrocleval meningiomas is the other. So these are two very humbling in my hands and in my knowledge. So these are tumors. We've already talked about them. They can present as either hyperfunction or hypofunction of the endocrine, or they can present as mass effect invasion. Then microadenomas, less than 10, more than 10, macroadenomas, giant and invasive adenomas. What are surgical approaches? We can go through the nose, that is a transsphenoidal approach. The standard microscopic, sublabial, paraseptal, or the endoscopic, endonasal, or the extended endonasal approaches. And conventional and the transcranial approaches going through the skull, it is conventional pterional, or you can have a skull-based approaches, transcavernous or transbasal approaches. So this has been my journey. It started with 25 years ago when I joined as faculty, nearly around what 715 cases. This is till 23. So close to 200 of microscopic. The initial curves are all microscopic, see. And then I changed to endoscopy, and a lot of my change variables are sitting here, Dr. Depasari, Dr. Suresh, and et al. And I was trained at AIIMS under microscope. And then you see these green bars also rising. And the transcranial approaches also now, because now we start chasing more of the cavernous sinus. That is where the transcranial approaches come in. So, what about the micro and the macro non-invasive pituitary adenomas? I personally feel that, look, I use a binostril endoscopic, completely endonasal, now turned completely into an endoscopic endonasal surgeon for pituitary adenomas. But I still feel for a microadenoma or a macroadenoma, except Cushing's, a unilateral or a binostril endoscopic approach or a microscopic approach are the same, actually, because you're working between the four blue lines, between the four of the cavernous sinus. And this is a standard position. I use the infralumbilical incision for the fat, and use the navigation for microadenomas, for recurrent adenomas. For standard macroadenomas, navigation is usually not required. And this is the standard area of approach. The nasal side, right or left, depends on the nasal deviation, septum deviation. So I first go towards the middle inferior turbinate, lateralize your middle turbinate, go to the choana, sphenodosteum, go to the opposite side. Like I said, the more sizable side is first, and then go to the opposite side. Do an uncinectomy if you have a tight, or you can even do a middle turbinectomy. And a standard adenoma, a micro or a macro, I don't do a middle turbinectomy. It's only in extended approaches I do a middle turbinectomy. Sphenodosteum widening and Bowmer and sphenoid septum removal. Sphenoidal stage, the floor is drilled, and you see the four blue lines, the cavernous sinus, the sera dural exposed. This is where in extended approach we go beyond, but this is a standard one. So, and that is the dural opening, in which the dura is opened from 5 o'clock to 7 o'clock. It is completely different from the microscope approach, in which it's a cruciate, and then you do an extracapsular dissection, then intracapsular dissection, and now immobilize the tumor and take it. Coming to microadenomas, this is our paper, which was first paper which was published on Cushing's disease in 2020, in which we found that the remission rate in endoscopic surgery was significantly better than microscopic surgery. The difference was 88% versus 56%. And in univariate analysis, endoscopic TNTS, day one morning cortisol, and day one ACTH levels were statistically significant predictors of remission. There's a latest paper in which we found that there were some cases of interesting cases of MR negative Cushing's disease. And these are the cases that my endocrinologist, Dr. Sabha must be knowing, Dr. Nikhil Tandon, Dr. Rajesh Khargawat. We have very good neuroendocrine collaboration. And we found that IPS is followed by GAD-DOTA PET, followed by a 3 Tesla pituitary perfusion MR. And then And in these MR negative ones, we do an standard ETS, that is endoscopic transsphenoidal, then maybe extended, explore the pituitary gland, the lateral sella, the cavernous sinus stalk, resort to hemihypophyseectomy if you do not find a tumor. In case we always, if there is an MR positive and there is, even for remission and recurrence, a non-remission recurrence, we always go till 3 surgeries. It's only after the 3rd surgery we resort to radiation therapy or gamma knife therapy or bilateral ectomy or any other sort, medical therapy as well. But if you have a if you have MR negative, it's only after 1 or 2 explorations that we actually go for these treatments. This is the algorithm that we based on.
As the stalk was explored, dura over the planum was cut, and normal pituitary stopped.
Yeah, these are the 3 tumors that we actually we found. One was in the lower part of the stalk, that is UCC. This is in the 2nd surgery. This is thickened stalk. And we found that this is my resident who had already given this video article in Neurosurgical Focus. That's the upper part of the stalk. You see that? And that is the one in which we actually found that the stalk was thickened. And that was at the junction of the stalk and the chiasm. So there is an ectopic location of these, not ectopic, per se ectopic Cushing's, but ectopic location beyond the sella, either in the cavernous sinus or at the lower part of the stalk or the upper part of the stalk. So a last publication, and it was presented in the SNO meeting, that 167 patients of who underwent 174 surgeries. Remission rate was significantly related to primary surgery. Patients who had single surgery were better than the redo ones. Adult patients did better than the pediatric ones. The post-operative plasma cortisol was the direct relating factor to remission. Post-operative day 1 ACTH levels. Low IRS level of NR4A1. These are some molecular markers that we were analyzing. Very small subset at the moment. Endoscopic endonasal transsphenoidal approach and histopathological evidence of adenoma. Many times the tumor was so small that it was nothing came, or maybe in some cases it just came as a normal pituitary tumor. In macroadenomas, it's again a straightforward pituitary between the 4 blue lines. So till now, it's all minimally invasive. Pituitary adenomas, microadenomas, macroadenomas are minimally invasive till now. If they have a standard supracellular extension, I'll just scroll video fast. So this is, again, a non-functional gonadotroph adenoma. And we take this ring of the bone at the cellular floor. Then the 5 o'clock or 7 o'clock expanded down. These are a couple of variations of and we took out the tumor from and that is the arachnoid bulging. And we push the arachnoid back, and we see some more tumor that we missed. And I use a cotton patty to push that arachnoid back. So this is yet not leaked. So we don't make it leak unless I'm sure that there's no tumor left, then pack it back with some fat. Those are 2 interesting cases in which we see there's a normal pituitary gland and pushed down, actually. And we saw the same thing when we were operating. This is usually unusual because most of the time in MRI, the normal pituitary gland is pushed up or one of the lateral sides. So we took out this from the supracellular. There was tumor, and then the arachnoid along with the tumor was bulging down in our field. We open that and get the tumor out. And we saw the stalk. These are unusual. I think I must have only seen 3 of my cases in which pituitary gland, the normal pituitary gland is pushed down. The tumor is above. And that is the pituitary stalk that we see. That is the pituitary stalk, and the last bit of tumor at the diaphragm. What about the invasive and giant ones? What are invasion? What is invasion? Invasion is into the cavernous sinus, bone, and sphenoid sinus. Invasion does not include supracellular extension. There is an MR-based classification. In 60s, imaging is present in nearly 2/3 of giant adenomas, nearly 1/3 of acromegalies, and very rare in Cushing's. It is said around 10 to 12%, but we found it very rare. There may be 2 or 3 patients in our series of 100, maybe 200, close to 200. Why surgery? Why should you perform surgery in invasive adenomas? Cavernous sinus extension, if you do a cytoreduction, it is better results with gamma knife radiosurgery in non-functional adenomas, and better results of medical therapy in functional adenomas. And the most important thing is these tumors, especially the acros, they present with severe headaches, especially when NOS3B or NOS4 extension of the cavernous sinus. Debulking of the cavernous sinus actually really helps for the headache. This is a standard classification of NOSP in 1, 0, 1, 2, 3, 3A, 3B, and 4, the modification. And this is the classification of Dr. Goel, and that is if it is grade 1 or grade 2, translational medial 1. If you see, the grade 2 are the ones which are actually the NOS 1, 2, 3, 4. So then beyond that, the elevation of the superior wall of the cavernous sinus and the 4, this is supradiaphragmatic subarachnoid extension, the one part of the giant ones. We have to understand that as per the WHO classification 2017, higher giant and invasive adenomas, non-remission, post-operative residual, and more progression, higher recurrence and higher mortality happens in these high-risk adenomas, which are sparsely granulated somatotrop adenomas. Lactotrop adenomas in men, very high dopamine resistance. And Cook cell corticotrop adenomas, silent corticotrop adenomas, and the PIT1 positive plurihormonal adenomas. There are enough series to prove that endoscope is better than microscope endonasally for not only for microadenomas or macroadenomas, and even for cavernous sinus extension. But we have to understand that once a tumor is grade 4 and total encasement of the intracavernous ICA, the gross total and resection is close to 0%. You can debulk, you cannot eradicate. In rare cases, you can eradicate. So what are the approaches? What is the difference? So I use the endoscopic endonasal and the extended endonasal for the invasion of the tumors, and transcranial for pterional or transcavernous approach. So if the tumor is a NOS3A, actually, this is GOEL2. So you just need a standard endoscopic approach, and you need a 0 and 30-degree scopes, and just fat packing. You don't need an Haddad flap. And if you have a 3B, and again GOEL2, you standard endonasal endoscopic approach, and you need 0 and 30-degree scopes. Again, fat packing, no Haddad flap. They are straightforward. So the moment it's 3, you need a 30-degree scope. You need more visualization. You may need a Doppler. You don't need to go lateral to the carotid. But the moment it goes beyond, you actually have to go look into those crevices of the cavernous sinus. And if it goes beyond the carotid, it comes NOS4. It is then a maximally invasive endonasal endoscopic extended approach. Here you have to do a more bone drilling. You have to do a middle turbinectomy and nasal septal flap for repair. So more bone drilling and more mucosal exposure. This is in steps. I'll not go into details of how a Haddad flap is taken. 2 horizontal cuts, one on the floor of the nasal septum and one on the roof. And here you actually bend down so that you preserve the olfactory mucosa. And this is the horizontal one, 5 millimeters or 3 millimeters from the mucocutaneous junction. And then you have a good size flap. Pleural incision is different. It is no longer a 3 o'clock to 7 o'clock. You go up as a T and then more up as an H, and you expose the suprasellar, and where the T is there, you are actually coagulating and dividing the anterior intercavernous sinus. So it's like a lying down H position, and open both the optic nerves. Let's expose both the optic nerves. And this is the repair. For an extended approach, is no longer the fat, which is important. You need a bath flap plug, a facial lata inlay, a Haddad flap onlay, and then some sphenoid, the fat in the sphenoid sinus, gel foam and glue and reinforcement as a tamponer. And this is a NOS4, the tumor which has gone lateral to the carotid, and just you drill the cellular floor, we drill the dorsum. And then we drill the planum as well. And we've taken a dural incision, 3 o'clock paper, take out the tumor from the cellular, supracellular. There's not too much of supracellular. And then we see the carotid there. That is the angle of the medial OCR. And that is the carotid. Doppler navigation, these are must here. And for hemostatic agents, plosive really helps here. And then we drill more lateral to the carotid. Open the dura at close to the MOCR and take out tumor, and then cut the dura lateral to the carotid there and take out some more tumor there. Main aim is not just a radical decompression, not a complete excision. And once the carotid is bare, you must have to cover it with the flap. And these are some cases in which we've done extended approach in a giant invasive adenoma with subfrontal retrocell cavernous sinus extension with near total excision. This is a case in which they had a post-operative apoplexy for the supracell, and we had to do a transcranial surgery along with that. This is the one in which we did a combined approach, a shake hand approach, an endonasal and a transcranial approach. I've only done 2 of such. I'm not. Both ultimately had some meningitis, long stays, so I don't do the shake hand approach. Dr. Andre Gotinos I learned it from him. So this is a bilateral cavernous sinus extension, nostril. Drill. This is a bilateral, these are very maximally invasive to the mucosa, bilateral turbinectomies. You're drilling lateral to the carotid on either sides. A lot of drilling of the planum, tuberculum, and then opening the cellular dura, then the supracellular, and coagulate the anterior intercavernous sinus. That's the supracellular tumor being removed. That is the delivery of the supracellular part. That is the gyrus rectus and A2. Then you're going lateral, the left side of the tumor, left to the carotid. Again, debulking. The aim is debulking. You must have a navigation and your Doppler always in hand. I've only, in my endonasal series, close to 500 cases, only 1 carotid injury. That is the one which was, by mistake, it's always the diamond drill. So never use a cutting drill or a cutting bar close to the MOCR. That is very rarely, but yes, the bone can be deficient there. That happened to me once. So I'm very worried about carotid here. So then a 3-layer packing with fat, inlay fascia, Hadad flap, and fat around that, and a good cover. So what about these are tumors in which there is a bilateral extension? We operated the tallest lady in the world. She's actually from West Bengal. Again, we could only remove radically some tumor left in bilateral cavernous sinuses. But what about these tumors, GOL3, GOL4? These are the ones which are beyond endoscopy. We have to understand that you had to open the cavernous sinus. These are the cases. I'll just rapidly go through the video. You do a standard ileal craniotomy, peel the 2 layers of the cavernous sinus. That's the foramen spinosum and the middle meningeal artery being drilled. And then that is the Parkinson's triangle. That's the Parkinson's triangle being opened. The more we found that more hypointensive tumor is on T2, the more fibrous it will be an extension. And then again, the role is radical decompression, preserve the carotid at any cost, preserve the cranial nerves, and give a good decompression. The goal is not complete excision, and then subjecting it to further medical therapy or radiosurgery. So this is again a unilateral invasive transcavernous approach. Again, a bilateral, a unilateral invasive, another one, a bilateral invasive, multi-compartmental. These are challenging tumors. There's some tumors, now we've got getting a lot of recurrent tumors, functional recurrent tumors, and they're very humbling. And they've been operated endonasally. Some have also had this lady is actually from Mumbai. She's an MBA, got her first surgery done in Chandigarh, and then that was endonasal. This tumor was left behind. My endocrinologist wanted to do medical therapy, but she was becoming resistant. We opened the cavernous sinus. That is the Parkinson's triangle. Decompress this tumor. And this is where you have to go hand in hand. Transcavernous, plus then you open the dura, open the oculomotor, the opticocarotid system, and that's the tumor bulge there. Open the falciform ligament, widen the opticocarotid system. So it's the distal ring of the carotid being opened, and that's a tumor in there. And that you're actually communicating these two areas. That is the supracellular. The moment you see this bulge, it is the paracellular extension. And the one which is going above, you can you join hands with the previous one. And surprisingly, this is complete. I got a normal IGF-1 and I was not aiming for that. And a complete remission. And this lady is doing well. There's another one. This patient have already received surgery plus gamma knife and recurred from the gamma knife. Again, acros are bad tumors. And again, you do a transcavernous approach. You see the tumor has become more fibrous. So endocrinologist wanted that if I can debulk some more, then medical therapy would be better. Or a redo gamma knife could be planned. So we open that, and that is, sorry, this is the other one. Then you open the dura, and that is the oculomotor trigone. And this is the superior wall of the cavernous. And if you see this portion, that is the Goel 3, actually. And that is close to the third nerve. Some of my friends, like Dr. Goto from Japan, he removes this tumor from endonasal approach. I'm very skeptical because this is a very sensitive area. Third nerve is very unforgiving. I want to see it if I want to remove it. Open the oculomotor trigone, decompress it, stay as much as away from the third nerve. And again, the patient did well, complete excision here, but IGF-1 could not be completely brought to normal. So this is our series published with some delay in neurology India. We found that giant pituitary adenomas with cavernous sinus extension, the poor factors, extension extension, retrocellular subfrontal cavernous sinus extension, multilobulated tumors, and T2 hypointense tumors. So to conclude, Cushing's disease, ACTH pituitary adenomas, high emission rate is significantly related to primary surgery, adult patients, postoperative day 1 plasma cortisol, and ACTH level 1. The low iris of NR4A1, endoscopic endonasal transnodal surgery, and a histopathological evidence of an adenoma. We found that there's a subset of MR negative Cushing's disease and approved by the IPSS and by the DOTA PET. 3 Tesla perfusion, pituitary perfusion MRI helps, and you must explore not only the pituitary gland but also the laterals. The lateral wall, that is the close to the carotid, and explore the cavernous sinus. And most important, the stalk. We found in our 6 cases, 3 were on the stalk, the lower and the outer part. In giant pituitary adenomas, very challenging tumors. The first surgery is the best surgery, and try to aim for the maximal resection. Otherwise, your patient may have a pituitary hemorrhage, which is the most feared complication. Endoscopic endonasal transnodal approach is a better extent of resection. Poor extent of resection for retrocellular subfrontal cavernous sinus extension and T2 hypointense tumors. And for cavernous sinus extension, this is what I thought is a good algorithm. If you have I combine the two. If you have a Goel 2 and NOS3, not Goel 1, Goel 2, NOS3A, 3B. So it's a standard endoscopic endonasal approach with 30 degrees, 45 degree scopes are very good. If you have a Goel 2, but NOS4, but it is a small tumor, hyper-intense on T2. Extended endonasal approach is very good. It is optimally invasive, good skull-based drilling, you can repair it well, but it becomes giant there. And it is going Goel 3, Goel 4. Along with that is a superior wall and a subarachnoid extension. No use putting your endoscope. The patient will be found dead the next day morning. The better to either do a shake hand, combine endonasal along with a transcranial or an extended transcavernous approach transcranially. Either you can do a arterial craniotomy or an FTOC, and center your open the opticocarotid system corridor by using the Dowling triangle. expose the Parkinson triangle and go intracavernous. And also you can take on the superior wall of the cavernous sinus by opening the oculomotor triangle. Thank you so much.
Thank you, Ashish. I think that has been a very comprehensive approach to pituitary tumors from the minimally invasive to maximally invasive. I have two questions. One is that you said endoscopic, you said you go more intracapsular than the extracapsular.
No, both. Depends.
Not necessarily.
Extracapsular is a must. If I have a microadenoma or a macroadenoma, the first, it's always an extracapsular first. Extracapsular helps. The tumor comes down. But you cannot remove a large cellular supracellular extension tumor just with extracapsular. There's no use. You are stretching too many things. So it's better just to create those lanes and decompress. This the extracapsular maneuver helps it to come down faster.
And second thing is you mentioned extensively about Cushing's. Sabha is here. The KM endocrine experience about Cushing's is very dismal in spite of very elaborate surgery. They say once a Cushing, always a Cushing, and at the end of maybe 20 years, they all die. That's what Sabha can correct me, because we have had lot of experience with surgery and then medical management, but Dr. Nalini Shah used to always say that they all, it's a very dismal thing. She was not at all happy. So is this the same experience that you have at your end? And Sabha is there, so I think you and Sabha can give comment on it, because Cushing's is a very dangerous problem.
Yeah, Cushing's, I think among all the pituitary adenomas, it is one Cushing's which is the most humbling. And the second is a Goel 4 subarachnoid extension of a giant adenoma. So these are the patients. The Cushing's will come back again and again, and the other patients actually die first. So what we have found in Cushing is yes, they recur. There is a recurrence. There can be a non-remission. We become much more radical now. And we actually were not so radical earlier, because we've become more radical because of our failures of gamma knife. We have a gamma knife, and we started using them even in a higher radiation protocol. We found that there was hardly any remission there, and the patients that we get, similar to probably to KM, we cannot afford a lot of medical therapy. So we became we realized that with microscope approach, we were not, even if we were radical, I used to operate the second time, the patient was still, there was no remission at all. But endoscopy, we are finding the reverse. We are finding a lot of high remission. And we are finding that that even if there's no very less recurrence, but yes, very less non-remission, but much more there is some element of recurrence also, maybe after 1 year or 2 years or maybe 5 years. You're absolutely right. Tumors recur, but we have made in protocol that we will be operating the second time and the third time. And I must say, I must thank my endocrinology. It is a wonderful department, and they actually, because we are overloaded with our own cases and with our AIMS waiting list, so-called never-ending 1.5 to 2 years, and this has to be reoperated. Otherwise, we'll have to do a bilateral adenectomy. So we end up operating, and then maybe a partial hypoxectomy or a complete hypoxectomy. That's after the third surgery. Correct. So I would say that they are much more, they are more radical than us. So it is a difficult disease.
A quick comment from Sabha on this, and then I will open for all the other people to comment on this. Very important.
So when Nalini ma'am used to say all Cushings would die, it was probably the earlier times when all Cushings used to be so bad that they would be bedridden and horizontal. Now with increasing awareness, we actually have Cushings who are milder, who actually come walking to our clinics and are diagnosed earlier. So the high morbidity and mortality which was seen initially is not as bad as it is today. After surgery, we do get remissions of 60 to 70% of patients, but at the end of the day, 1/3 of them would eventually recur. So at the end, only half of them are actually cured. Half of them would be in recurrence, would require radiotherapy. And what we actually prefer as our center is to do a whole cellular radiation rather than a focused gamma knife, to kill whatever tumor cells are there in whatever extent periphery of the cella, so that they don't recur. So that is all what I.
Thank you, Sabha. Anybody has a comment? Yes, Dr. Devpujari and Kaustubh.
So my only comment is, sorry, Kaustubh, I will just take less than a minute. My only comment is that operating second or third time should not be considered a failure in Cushing's.
Absolutely.
And I think that is the only thing I would like to say, that in acromegaly, surprisingly, I find that gamma knife for radiation is more effective, but in Cushing's it is not. So we have to consider repeated surgery, and you should tell patient what is the remission rate and what is the recurrence rate upfront, so that you do not have problems when the patient comes back with a recurrence.
Yes, sir.
I just had to make one comment
Uh,
regarding Cushing's, that all these patients used to come with very bad dilated cardiomyopathies, very bad. And that was the reason for their downfall. Even in acromegaly, we see HOCM a lot of, so the cardiac status of the patient becomes important. But if a patient has come in earlier stages, now, as sir said, second surgery or third surgery should not be a problem, because they do not respond well to radiation.
yes.
I think we can even, I think the awareness, even if people are coming even with the slight weight gain without, that is one thing which is actually happening. So I just operated a lady around 60, and this is, I think, last week, 64-year-old, and I was, and there was a bit weight gain for the last 6 months. And it was very doubtful that small lesion is, but the neuroendocrine, they evaluated, they said it's squishing, you have to go in. And it was very tiny bit of lesion, and we completely removed it. And that's probably, we have way less patients who are above 50 actually. But I think that consciousness, awareness of that weight gain is there.
Correct. Yes.
Any other comment from our esteemed panelists? Any other guests? Anybody else? There are no questions.
Also Ashish, our understanding has improved. In the last 10 years, if you see, we have, better understood this pituitary adenoma, no matter what type of pituitary adenoma. But the biology is very well understood, and so is our technical assistance. Now we have got endoscopy and so many other gadgets to use to take care of this pituitary adenoma. So it's an improvement general, from everywhere.
And more interactions also. I think
And
last
more interactions
What
also.
about the
हम हम
perfusion?
हम ये सोचते हैं कि डॉक्टर पुजारी निकाल सकता है वो वीडियो में, तो मैं भी निकालता, तो कोशिश करेंगे ना, तो
What about
that
perfusion?
concept comes in.
Ashish, what
Yes,
about
yes.
perfusion imaging? You mentioned about the perfusion
Yeah,
imaging. That helps.
actually, our neuroradiology professor, Dr. Ajay Garg, and these MR negative ones, he said, and there was actually one of our resident thesis, and he said, I would not want to do perfusion MR for the 3 Tesla for these small microadenomas. And then we said that there are two, and our endocrinology felt that they felt that there's a central gradient on IPSS, and they're very sure, but we cannot see any adenoma on the MR. And we found that at the lower part of the stalk, there was some increased fusion, and we explored that, and the tumor was there.
That's great. Actually,
Yeah, that's very good.
I think if there are no questions, we are over time. So thank you, Ashish, and you have
Thank you,
been
everyone, sir. Thank you.
wonderful. Sabha, Ashish, and Kaustubh. I think we learned a lot, and of our esteemed panelists and Dev Pujari sir, Suresh Sankla sir, everybody. And thank you very much. And I would
Walid,
like.
thank you, Walid. Very
Thank
nice.
you very much.
Thank you.
Thank you, Walid. Thank you for your comments.
Thank you very much. Thanks.
Thank you.
One
Abhay,
webinar,
I
I've
wanted
learned
to
a
say-
lot today. Thank you.
Yeah, Ashish. Thank you very much. Ashish, Abhay, you want to make some comments?
No, that's it. That thank everyone. Thank all of them for accepting my invitation and spending some time today here. Thank you.
Sorry for troubling you, Abhay. My traffic was.
No, that's fine, sir. That's fine, sir. It was
Traffic is
very
common
excellent
now.
talk, and that's
Thank you.
Thank you.
Thank you. Have a
Thank
good
you. Thank you, everybody.
Thank you. Bye.